We're doing a re-record of the clinical records webinar as we had some difficulties with our technology. So thank you very much for watching us again. Over to you, Lindsay.
Thanks, Bridget. Kia ora, I'm Lindsay Barwick and I'm the Provider Monitoring Manager here at ACC. My background is physiotherapy and I've worked here for just over 8 years now. So prior to working in the provider monitoring space, I worked in treatment injury. So I've had plenty of experience at both writing and looking at clinical notes. Bridget.
Hi, I'm Bridget Gunn, registered nurse, class of 93. My experience includes rehab and surgery in both public and private sector. I've been working for ACC for about 8 years now, and I started in treatment injury doing complex cover assessment. I'm now a clinical advisor working across all types of claims. We also have Karen sitting in with us who's going to help answer questions at the end of this recording.
Okay, so here is the agenda. We'll go through the reasons why your clinical notes are important, then what we need from an ACC perspective. We'll show you some real life examples of what we see and what good looks like. Then we'll have a brief summary, show you some of the resources available, and then answer some of your questions. So straight into it, why your clinical notes are important. We expect that you're going to meet the standards set by your own professional body or association. It is not our role to check this, but if we feel that you have not met those standards, then we may notify your professional body.
So obviously they're important for your clients. In particular, so they can continue to be treated by someone else if required. This was particularly relevant during the COVID pandemic, which, as we know, we're still feeling the effects of. And it's really important if your client needs extra support or treatment from us. So it's crucial to have all patient history, treatment, and progress documented.
So the fact that we have ACC, which is no blame, of course means that we cannot be sued, which is great. But there are times where it is important to protect yourself by ensuring you have accurately documented your treatment. An example of this might be if a client suffers an injury during the course of your treatment. If a treatment injury is lodged, we will look at the clinical notes to ascertain whether the nature and force of the treatment being provided has more likely than not caused the claimed injury. And whilst assessing a claim for a treatment injury, we also consider whether there may be a risk of harm to the public. So we would request a peer review regarding this, and if such a belief is confirmed, then we will notify your professional body. Another example in the provider monitoring space would be if we see prolonged treatment with no evidence of any outcome or progress, and if we consider this to be overtreatment and developing a therapist-patient reliance, then we will also consider notification to your professional body as a risk of harm. It is important, therefore, to document the rationale for your treatment. So most of the time, as providers, you receive a pre-approved number of treatments once a claim is accepted for cover. So we trust you to be giving treatment and invoicing us based on it meeting the funding criteria. Unfortunately, in the day-to-day work of our provider monitoring team, we do see evidence of fraud, waste, and abuse. We therefore regularly request clinical notes to ensure the treatment you provide meets the funding criteria. And the Working Together handbook you can see on your screen details that criteria. In this handbook, you will also find links to our position statements relating to treatment of family and those close to you, treatment of colleagues, same-day allied health treatment, treating clients in a sports setting, and seeking payment for treatment by allied health students. Some of these position statements require specific things to be written in your clinical notes, so well worth a look at. So I just wanted to go over two key criteria that I just spoke about, which we specifically look for. They are causation and necessary and appropriate. So typical examples of what our provider monitoring teams see are sprain, strain type injuries without a significant force during the accident event, which are treated for several months after the accident event and or given a significant number of treatments. We would generally expect these types of injuries to resolve within a few weeks with minimal input required. Therefore, when we see a pattern of potential overtreatment developing, we will always look into this further. And if we determine the criteria hasn't been met, then we may recover payment.
So your clinical records are important to us. This is where the rubber meets the road, and your records come into their own supporting your patient by helping us do our job. First, a little background about the clinical advisor space in ACC. We are registered health providers. My team includes physio, hand therapists, nurses, and the wider clinical teams include psychologists, pharmacists, doctors, and specialists, for example, orthopedic surgeons, general surgeons, urologists. Many of these advisors also work in private and public practice. Because we analyse and interpret clinical records in a way our frontline colleagues can understand, they refer claims to us for a clinical opinion about an aspect of the client's treatment, rehabilitation, or diagnosis. And the important part here is that we rely on good quality clinical records from our providers in lieu of being able to physically assess the client ourselves. So we're looking for clear clinical evidence, and this is certainly true of most records. But as the saying goes, if it's not written down, it didn't happen. So when looking at cover, for the vast majority of claims, of course, ACC makes an instant cover decision. However, complex claims require further investigation to determine whether they meet the legislative criteria for cover. So complex claims are delayed lodgement, claims that are lodged way outside the expected time frame, for example, a sprain lodged 12 months after the accident event. Workplace gradual process, infections and disease ranging from your carpal tunnel and cubital tunnel. At the extreme end, the lung cancers from asbestos, which thankfully don't come to me. Mental injury. These are assessed by psychology advisors, and again, they don't come to me. Treatment injury, this is where we see things like a vertebral artery dissection caused by manipulation by a registered health professional. Where cover is established, we also need good clinical records to help us consider requests for treatment and support, what ACC call entitlements. This is easy enough if the client has had a foot injury and now needs an orthotic or a mobility aid. But when you consider we also receive requests for surgery and housing and vehicle modifications, this becomes a bit more tricky, and we rely heavily on the clinical records you provide. For us, it needs to be clear that the requested treatment or equipment or support is needed by the client because of the covered injury and clearly not for an underlying condition. This is causation, as Lindsay was talking about before. Simply put, we need to be able to see that the support treatment is requested for an injury caused by an accident event and why the support or treatment is needed and what the expected outcome is. So this is true again for additional cover. For example, a claim that's lodged for a knee sprain now has a surgery request. We need to be able to see how a knee sprain evolved into a meniscal tear. And if this is an acute injury, because sometimes it isn't, it really helps the client when you have written in the initial presentation or subsequent records that you suspect an acute meniscal injury and why. And we can see this in the supporting information. We also need your records for additional treatment. You've completed the allocated amount of treatments, but the client is still symptomatic. If the rationale for further treatment is clear, including current function, plan, and goal, this helps us make a timely decision to provide support our clients need. To sum up, we need good clinical records so that we can help our clients recover. This doesn't need to be a weighty tome. In addition to the date of treatment, client name and claim number, we just need to see a really good description of your diagnosis, including differential diagnosis as well, if relevant, the mechanism of injury, causation, your subjective and objective assessment, including functional limitations, what treatment you did and what the outcome was. Measurements are good. And what is the plan and what your goals are for that client. Formats such as SOTAP and SOAP are great for this. And if you use abbreviations or acronyms, please make sure these are universally understood.
Thanks, Bridget. So that's a perfect lead into what we need. What's the extra information that ACC requires? So basically on the left-hand side of the screen there, you can see we need the claim number, the accident event, and the injury. Now, if sometimes we also need causation, that is really clear most of the time when it's an acute event. But sometimes where a significant period of time has passed since the accident occurred, it may be less clear. So just make sure you explain this in your notes. And if you're a time-based biller, ensure you document the time taken that you are providing direct treatment to the covered injury and invoice accordingly. We do have a module to complete, which you'll find on our website for anyone who's unsure. So just a little case study here. So Bridget's just out walking, rolls her ankle on some uneven ground because she's quite clumsy like that.
True story.
Walks home, hobbling away, quite sore. A few days later, still quite sore, a little bit of swelling remains. So she goes to her local provider. So what do we want in your notes? What should they include? So we've got the claim number there. We've got the accident event, which is rolled ankle whilst walking. We have the diagnosis of the right lateral ankle sprain and the read code. Causation, as I said earlier, this is really obvious. It's an acute injury. She's had no previous issues with it. The assessment and treatment should be detailed well. Now, effectiveness of treatment, this is a real interesting one. So we always get things like less pain, decreased swelling, increased dorsiflexion. Chuck a measure in there. Let's see exactly what functional limitation there is. And tolerated well does not describe how effective a treatment is. It's not a torture session. They don't need to tolerate it, or hopefully they shouldn't. And the plan, what are you going to do next? Reviewing in 1 week is only part of your story. What are you going to review and how are you going to do it? Are you intending to progress, repeat treatment? If so, just tell us how. And the goals, obviously always SMART, outcome measures appropriate, and it just really helps us to understand how well the client's progressing. So this is a good example. So in our work in the provider monitoring team, we are constantly asked to provide examples of what good looks like. So we also recognize that as clinicians, you're pretty time poor. And often it is your clinical notes that just get left and just get the bare minimum attention. But you can see from these clinical notes, they're actually pretty snappy, to the point. They don't take that long to write. So your subjective is pretty obvious. It's what they tell you. Your objective, it's got some good measures. The treatment is detailed. It can be reproduced. The analysis shows how well the client's progressing, how effective the treatment was. And the review is, again, pretty detailed about pain. Probably only require absolute minimal treatment and discharge with further advice on self-management. So, as Bridget mentioned earlier, this is a really good example of where we would use the SOTAP notes format. It's just really clear. So for those that have asked what format we like them in, this is just a clear example. You don't have to do them like this, but for those that are wanting a suggestion, this is a pretty good one.
So this is where we're going to show you a few examples of some of the quality of notes that we are getting through. We're just going to pause over the examples, and if you can see things like claim number, accident, event, and injury, just so you can see sometimes how hard it is for us. This one here, it's obviously an extreme case, which I call variously a shambles and hieroglyphic. This is a snip from notes, so it's incomplete, but it does give you an understanding of how difficult it can be to find the information we need. And unfortunately, when I look at notes like this and can't read them, they will get disregarded, which may impact on the outcome for the client. I think just as a very baseline, if you're handwriting notes, it needs to be legible. So just, pause for a moment and look at whether or not in this one you can see an injury, what they're treating.
Thanks, Bridget. We'll move on to example 2. So a little bit more legible, but still a little bit difficult to read in parts. I can see that we're treating the left elbow, but I don't have a specific injury here that we're treating. Some information about reduced range of movement of the radial ulnar joint, but again, doesn't really give me a measure. Don't know what that means. And we don't have any analysis of how effective the treatment was or what the plan is going forward. So falling short on a number of points there.
This one is mostly legible, but it's a bit hard to work out what the actual injury is. I can see that there's some back pain, I think. Can't actually see what the diagnosis is and what happened, what is the plan going forward. Not particularly helpful from a clinical advice perspective.
No, there's definitely a pattern here in the notes that we're seeing. Certainly not detailed enough to give us any useful information. So example number 4. So we have an injury here that says there's a left ankle injury, but it's really unclear how this happened. There's no information about the accident event. I can't even tell if this is an acute injury, and there's a lot of information relating to potential underlying biomechanical issues, but I'm really struggling to understand what's being treated and whether we're treating a covered injury and what may be underlying. Just very difficult. So if Bridget received these notes alongside a request for orthotics potentially, there'd probably be a whole lot of questions rather than answers when she's looking at these notes.
Yeah, Lindsay, I wouldn't be able to approve an orthotic or, clinically support it, based on this note, this set of notes. As they are, I would have more questions, definitely.
Cool. So the next couple of examples just show examples of copying and pasting when using practice management systems. So you can see from entries 1 to 4, there are some changes to the treatment, but there's still a main bulk of copying and pasting. And then for the next 5, there's actually no change at all. So From a monitoring perspective, I'm really wondering why someone's receiving the same treatment week in, week out.
And from a clinical advice perspective, I would look at this, and particularly if you were requesting more treatments, I would be wondering why, because I have no idea what you actually did for those last 5 treatments.
Yeah. So this is another one. So I've put in blue the things that are the changes, but you can see the black stuff is all the stuff that the stuff in blue is all the copying and pasting. So it makes it really unclear and difficult to understand exactly what's happening. So these are all subjective things. And there's a note here on the second entry of not getting any relief from acupuncture sessions. Then that's repeated the week after and the week after. Then it says stopped acupuncture this week. And the following week, it says exactly the same. But did they stop it that week or did they stop it the week before? Then the following week, it says stopped acupuncture. But I'm pretty sure we already know that. So it's good that there's some updates, but having all the old stuff in there just clouds the picture.
So now we've shown you some of the very average records we see, and having trawled through masses of clinical records to get these, we did find an example of what good looks like.
Yep, so these are follow-up notes. We have a claim number, the injury, the accident event, and causation is really clear. We have a detailed subjective, an objective assessment with measures. The treatment is detailed well alongside the home exercise program. And we also have post-treatment measure to demonstrate how effective the treatment was. Although it does say tolerated session well, but at least we know they didn't cry. So lastly, the plan could do with expanding upon, but in general, a pretty good set of notes.
So we hope from that you have a better understanding of what we need to see in your records and why it's really important. We have some internal resources here that you also may find helpful, and you can find them on our website. So we have Core of Causation, Your Responsibilities, Understanding Causation, what ACC covers, and the Working Together document that Lindsay referred to earlier. I would also encourage you to have a look at your contracts on our website, which can be quite easily found under the Resources tab. We have other resources as well here, Privacy Commissioner and your Health Information Privacy Code.
Okay, so to wrap up, we are all aiming to help New Zealanders to recover from their injuries and at the same time ensuring that the scheme remains sustainable. Your clinical notes are key to ensuring we can support you to provide the treatment your patients need. And remember, there are just 4 extra bits that ACC requires. That's the claim number, the injury, the accident event, and the causal link. So thank you all for listening. And we're now going to cover some of the questions that you've asked.
Thank you, Lindsay and Bridget. So I do have some questions for you that were submitted during the registration process for this webinar. So the first question is, how long does ACC need providers to keep records for?
So ACC themselves they don't have that requirement. That requirement is the Health Information Privacy Code, which I've just popped back on the screen. So in there, it notes that all health information should be stored for 10 years.
Thank you. And does ACC have a preferred template?
No, I think we just covered that off a little bit in the presentation where we don't have a preferred template. As long as you have the information that we've covered in the presentation in your notes, that's all we ask. We recognise that SOAP notes are pretty clear format for people to write their notes though.
Okay, great. And does ACC have a preference for outcome measures?
Again, no, in general is the answer, but there are some contractual requirements with certain contracts that will state exactly what outcome measures are required. So if you are working as a contractor provider, really important to just read that contract through to see what the requirements are. And again, you'll find that on our website.
Thank you. And what is ACC's expectations on the use of acronyms?
Again, more of a professional body standards. So what we covered it off, I think Bridget said that they should be universally understood, but often your professional body will have a list of those which are acceptable. But for ACC purposes, if in doubt, write it out in full. But yeah, we don't have any specific requirements.
Okay. And when notes are requested by ACC, how much is expected to be redacted?
Well, when ACC requests information, we always request it for a specific purpose. So it's important to understand the purpose that we're requesting that information for and just giving us the relevant information for that request. Anything else should be redacted.
Okay. And are there different records needed for telehealth? And what about consent?
Yeah, the telehealth guidelines, there are ACC telehealth guidelines on our website. So always refer to those. And I think most professional bodies have telehealth guidelines too, which should be referred to.
Cool, thank you for that. So now we do acknowledge that not all questions were able to be answered, as some that we received were out of scope for this webinar.
Okay, thanks, Karen.
Thank you.
So just to let you know that if you do have any questions, that you can direct them to our provider helpline. So the number and the email address is on the presentation. And thank you so much for listening.
Thank you all. Haere rā.